Okay, so to clot or not. When we have been talking about the word thrombus, we have been using it to refer to any kind of blood clot. When in reality, when we say the word thrombus, we mean a clot that is harmful. So when we have a clot at a site of tissue damage to the endothelial cells of the blood vessel, that's a protective clot. That gives us hemostasis. That's good. And this clot, when it forms, it's got those built-in elements that we've talked about, it, which prevent it from forming this big, huge clot. And so even at the site of injury, we can clearly see that there is going to be blood flow throughout that blood vessel. It's not going to be as great as it was before until this whole clot contracts down and dissolves over time, but there will be adequate blood flow downstream. In contrast to that, when we're using the word thrombus, we are thinking a bad clot, one that's totally obstructing blood flow or giving us a pathological, a disease state. And the most common cause of a thrombotic clot is where you have atherosclerosis in blood vessels, and when they fracture from whatever reason, that triggers the formation of a clot, which can completely block the blood flow in that area. And this is what typically leads to strokes and or heart attacks, as well as similar things in other blood vessels. All right. So now let's talk about things that occur when blood clotting is not happening, or how things that affect blood clotting from happening. I want to talk for a second about the liver. And the liver synthesizes something that are called bile salts. We'll learn a little bit about this in the digestive system. And those bile salts get released from the liver and they travel into your small intestine. And when they're in your small intestine, that allows the cells of the small intestine to absorb dietary vitamin K from the food you're eating. And so now we have vitamin K floating around in the blood, and that vitamin K then allows the liver to make our clotting factors, all those inactive proteins in coagulation cascade. If you have inadequate vitamin K, then you can't get those coagulation factors being made. So how do you get a vitamin K deficiency? Well, by having a crappy diet. If all you're eating are fiery hot Cheetos every day, you're going to be vitamin K deficient. Or if you have inadequate fat absorption because you have some pancreatic diseases or some liver diseases. Or if you lose your colony of bacteria in your colon, which when they're breaking down foodstuffs will produce vitamin K. But the most common cause of a vitamin K deficiency is just the fact of being born, because your liver is not quite mature. So it's often offered to parents of newborns, especially if those newborns are going to remain in the hospital or have any other kind of disease process, to give that newborn baby a shot of vitamin K to make sure that that baby can have normal coagulation factors. And we also can prevent vitamin K from doing its work by giving an antagonist to it, which we'll talk about again later. So where does this vitamin K affect the blood clotting cascade? So you don't have to memorize these things, but look at the areas that are circled. And what I want you to notice, it's both intrinsic pathway and extrinsic pathway. Both have factors affected by vitamin K, as well as that final common pathway has factors affected by it. So that brings me to something called hemophilia, because some of these factors are affected by vitamin K. But even if you have normal vitamin K levels, you can have bleeding from having the disease process known as hemophilia. And there's actually two different types of hemophilia. Both are affecting factors in the intrinsic factor. A deficiency of factor 8 is more common, but there are also deficiencies of factor 9 that are possible. And both of these occur with an X-linked recessive gene. So what does that mean? Well, dad only has one X. So if he has the defective gene, it's going to be expressed. But mom has two X's, so like an heir and a spare. So even if one is affected and doesn't work properly, she still has one X, so she still has factor 8 and factor 9 working properly. So let's look at the genetics of inheritance a little bit. If mom is heterozygous and is a carrier for the gene, what that means, if she gives the defective gene along with dad giving a normal Y, then a son will have the disease because it's not carried on the Y, it's only carried on the X. Now, if she gives the defective gene and dad gives a normal X, that means the daughter will be a carrier. But if mom donates her normal X, that means that both a son and a daughter with the X or the Y coming from dad will be absolutely normal and will not be carriers and will not have disease. If dad, on the other hand, has the disease, that means his X is not normal. And so if he has daughters, they had to have two X's, one from each parent. So if mom did not have the gene, but dad had the disease, that means their daughters would all be carriers because dad has to donate the X. But it also means their sons would not have the disease because dad has to donate the Y in order to have a son. Now, if we put both of these parents together, we have a dad with the disease and a mom who is a carrier. Only if she has a son and she gave the unaffected X would she have a child that has a normal inheritance. If she gave her X that was a carrier for it and had a daughter, then that daughter would actually have the disease because the dad would also be contributing an X that was a carrier, and then the daughter doesn't have a normal X. So this is why hemophilia can exist in women, but is much less common than in male. So if dad has the disease and has sons, mom has to pass on the carrier gene for the son to be effective. And so this can be used to trace back to figure out who in a family was a carrier when a son shows up or daughter shows up with a disease. And this is what happened in the royal families in Europe and in Prussia. And so if you're interested in this in genealogy and history, what you can see is the squares are all the boys, and a red square means that the son had hemophilia. And based on that, if the son has hemophilia, we know the mom has to be a carrier because dad had to donate the Y. And so the circles are the moms. And so if the circle is half red, that means she has to be a carrier. And if we look at all these royal families, what we determined is it all traces back to Queen Victoria having been a spontaneously developing, becoming a carrier for hemophilia, because there was no hemophilia in any of the royal families before Queen Victoria had her children, where she had an affected son as well as carrier daughters. In case you're worried about the modern monarchy, if you look on the far left side of this, what you will see is the royal family in England. And so, yes, no, Elizabeth and Philip and Charles and William and Harry, they're all fine. None of that gene carried over into this family. So now let's talk about some drugs or medications that can affect coagulation. And the first category are what are known as platelet activation inhibitors. In other words, they're going to block the activation of the platelets when they're exposed to the subendothelial collagen. And the first drug is aspirin. And this prevents the activation for the lifespan of the platelet, which hopefully you recall is 7 to 10 days. This is irreversible. So one aspirin tablet means for the next 7 to 10 days, those platelets that were formed when you took that aspirin will not be able to be activated and help you form a platelet plug, thereby increasing your bruising and your bleeding. And now another category of drug, which are inhibitors, are non-steroidal anti-inflammatory drugs, or NSAIDs. Now these are slightly different in that this is a reversible inhibition. In other words, this inhibition only occurs while you have therapeutic blood levels of your Advil, your Aleve, your Motrin, or anything like that. So think ibuprofen, naproxen, and those related compounds. So if you take one of those tablets today, then you will have platelet inactivation today, but tomorrow when that drug has no discernible blood level, then your platelets are back to full force. And so I've started a table so that you can see this. Our first process is the platelet plug inhibition. The class of drugs are these antiplatelet drugs, which can be reversible NSAIDs or the irreversible aspirin products. Our second method of changing what has happened is to interfere with coagulation cascades so that we inhibit clot formation. And there's two different drugs which are commonly given to patients who develop bad blood clots or those thrombi. We want to prevent new thrombi from forming. The first of these is a drug known as heparin, which was one of those things that could be in the little capillary tube or the blood tube to prevent blood from clotting when we were determining hematocrit. And the way heparin works is that it activates antithrombin 3, which, as you recall, hit multiple places in the intrinsic pathway and the final common pathway. And so it destroys those activated factors to prevent the formation of thrombin. The other major drug in this category is warfarin, also known as Coumadin, and this works on vitamin K. So it decreases the vitamin K activity. And so this is the four purple circles. These are the factors which require a cofactor of vitamin K in order to form the activated factor. So they're both intrinsic factor, extrinsic factor, as well as in the common pathway. So I'm going to add these to the chart. These are drugs we give to prevent more bad blood clots from forming. Intravenously, we can give heparin, and as a pill, we give warfarin. Heparin is not a pill, and warfarin is not intravenous. And then our third grouping are those that will affect fibrinolysis, which means we already have a clot formed and we want to break it down, as I talked about in a stroke or a myocardial infarction or a heart attack. And these are all related to that tissue plasminogen activator, that TPA. We now have synthetic TPA that we can give, and we also have related drugs called streptokinase and urokinase, which work on different parts to affect fibrinolysis as well. So with that, we are done learning all about the anatomy and physiology of blood, and I will see you as we continue our exploration of the cardiovascular system. Thank you for all your hard work.